department, but I tell my students because we cannot expect everybody in the same spectrum to come and buy everything and anything that is available in the market. I'm a poor man, so I needed to believe myself more than the gadgets. Now, if your ISQ value, that is implant stability quotient, is less than 40, this is the least desired. That is, the quality of the bone is very poor. If the ISQ value is exceeding more than 55, that means it's got a good quality of bone. So these are the things, mechanical devices the supporting devices that can be used during your surgical procedure. Now, am I clear in this thing? Sorry. Any question? Now, prosthodontically, we are comfortable when the implants are placed. Relative. I'm sorry, sudden exposure to this. AC la ஒண்ணு கிடையாதுங்க. அந்த குளிர்ல இருந்து இங்க வந்து இறங்குறது அம்மாவே பறந்து வர மாதிரி வருது. Yes, the relative parallelism between the implants matters a lot in designing a prosthesis. In terms of biomechanics, because we are keeping a biomechanical device. It should be very friendly when it generates a load to the long axis of the implant. The bone can tolerate a force acting on the long axis, not in a tangential direction. That's the most important thing when you start, because if you look at the natural teeth, how it is, it follows the curvature, anterior posterior direction and in the medial lateral direction, and we have a definite plane of occlusion. We have a neutral zone of muscles, forces falling. So same thing should be developed to this biomechanical device that you are going to have in the patient's room. That's the most important. So you need to plan in such a way that your prosthesis over the implant should generate the bone to the long axis to the bone. That is the mantra that you needed to have in your mind, no matter where you're going to have the implants placed. Will it be a multiple tooth or multiple teeth or a overdenture? The relative parallelism matters a lot. That is how it is. Now, anterior teeth. Most important thing in anterior teeth is the aesthetics. Never place the implant in an embrasure area, because it can never develop an emergence profile. I repeat it again, never ever place an implant in a multiple restoration in an embrasure area. It is difficult to develop an emergence profile. So as a beginner, what you can do a wax-up. Now you have, because of all this problem, now we have from the freehand technique, people has gone to the digital era of going to the guided surgery. But then we have the dynamic navigation. Okay? If you are too good with your placement with your hand, I don't think you need all this guided surgery and extra dynamic navigation. Probably, yes, you can influence the patient by saying that you have adequate additional gadgets and all those things. Can you see the relative parallelism here? This is all freehand technique done by me, shown to my students. Now, anterior again. Then the next question arises, where exactly I am going to have the implant placed for a central incisor? Singular. Exactly locate the singular and place the implant. You can develop a good emergence profile. Make sure you give an adequate gap between the natural teeth and the implant and between the implant also. This is how it is clinically. Beautifully placed. Now, when you connect the impression coping, they will not go for a crisscross. It will be exactly straight. Always remember the September 11 Twin Tower attack. That should be your position of your implant. That was disaster. Killed so many people. But this is the conducive position for us to construct a good prosthesis. Can you see this? And it is so beautiful for me to make an impression. I am not at the mercy of the laboratory dental care. I can always dictate them. So he is the person to receive the message from us. And we are not at his disposal. I'm telling you again, he is at our mercy. We are not at his disposal. In a mother is a lot of them, laugh and say, they put them up for me. And I'll so be that, or see it. So, this is for the ease of fabrication of the processes. This is called September 11 of placement of the implant. No? In the anterior maxilla and the posterior mandible. So I am good, we are very thorough. Nothing is going to happen to the load carrying implant by placing the implant properly. So this is the most important process on the case. Clear? Because you are giving, no matter who is placing the implant is not the question or the problem here. How we are going to place matters a lot. If you want the implant to be very successful at it for 10 years and beyond that, then this is how it should be. Of course, we may not get the same condition, but we do have for compromised condition to manage the same. Now, the most important thing in the anterior mandible, I spoke about the long axis and everything. How are we going to place in the aesthetically commanding area, what we call as a 3D position? That is, implant placement should be assessed anterior posterior, that is labiopalatally or portopalatal. Then mesiodistal, then cervico-incisive. Superior, inferior, anterior, posterior, medial, lateral. So 3 dimensions should be assessed. Mesiodistal position, 1.5 mm to 2 mm between the tooth and 3 mm between the adjacent implant. That is why we want to know the 1.2 mm is, that is, we should not jeopardize our touch the adjacent tooth. First thing. Second thing is, buccolingual position inside from the line joining the adjacent gingival margin. I'll explain to you. Apicocarolingual position, 3 mm apically from the gingival margin of the implant. All these people who write this, especially, this is all books are from the Brennemark's books only, that's just not given a mission, another thing. The thing is, they think that we are too good in observing every minute detail. He says 3 mm. You cannot expect me that anticipation and the anxiety when I open that, you cannot take me a scale and put it in the patient's mouth. That's true for 3 mm. But rather, I would be happy if they had to mention, look for the adjacent tooth and cemento-enamel junction and place up to the cemento. That is beautiful way of explanation. That is where I always say, Indians are always smarter than the rest. Do we need a guide for this? No. Do we need a computer for this? No. We have beautiful as we look into the adjacent things and we can place the implant beautiful. So, if the tooth is in a normal position, look for the cemento-enamel junction, have the implant sunk up to the level of the cemento-enamel junction, and otherwise a normal condition where you can develop good emergence profile. Here are some of the cases that we did in the college. Yes. I am again within 3 millimeters away from the margins, palatal. Mesiodistally away from the adjacent tooth by 3 millimeters. Yeah? Apicocarolingual, can you see the C junction? No, these are the ideal conditions. The next question comes. So what would happen if there is a cervical abrasion and its exposure of the tooth? You needed to go up to the crestal of the bone that is actually seen in the implant site. Suppose if there is a gingival recession, if there is an exposure of the cement, where do you place the implant? It will go to the crestal level bone of the implant site. That is the indication. Am I clear? Any confusion here? So this is for 3D position. Now, the next thing is, most important thing to assess is, you draw an imaginary line from cingulum of the lateral and cingulum of the center. If your implant axis or falls parallel to that, that means